and I have the privilege of working with amazing people throughout this province and beyond as a research navigation and community facilitation lead with both the Interior Health Research Department and the BC Support Unit Interior Centre. I would like to start by gratefully acknowledging the territory that I'm currently on, and I welcome you to share your acknowledgement into the chat box as I talk. I'm a fifth-generation settler of mixed European ancestry. My mother's family was from England, and my father's family was from Sweden. I've lived most of my life on the traditional, ancestral, unceded, and currently occupied territory of the Syilx Okanagan Nation. I was born here, and so was my daughter, Sarah, and so my heartstrings are deeply rooted to both the land and to the water, specifically to Okanagan Lake. I'm constantly reminded of the beauty of the land every time I look out my window or step outside, and I don't take any of this for granted. And with this gratitude in my heart, I want to acknowledge the Syilx Okanagan Nation territory, who have been stewards and protectors of the land since time immemorial. So a little bit about Research Week 2024. So IH Research Week 2024 is hosted in partnership with the IH Research Department, the BC Support Unit Interior Centre, and UBC Okanagan. This year, we have planned 3 days of remarkable dialogues and presentations that aspire to improve the health and well-being of our communities, both close to home and beyond. The 3 days consist of 2 consecutive days online, so this is day 2, October 16th, followed by 2 separate in-person events happening on Friday, October 18th. We're excited to share that we'll also be hosting the event titled Indigenous-Led Health Research, Knowledge, Understandings, and Wisdom, coming this spring 2025. We'll send out further information regarding this event early next year, and we hope you can join us for all the events, and we thank you so much again for supporting IH Research Week. So a few housekeeping items before we start. There's a closed captioning box, which can be moved to your preference by clicking and dragging it to where you'd like. To turn off closed captioning, select the Hide Caption button on the menu bar. For questions, please type questions or comments for the speakers into the chat box during the presentation. Questions will be read at the end of the presentation unless otherwise requested by the speaker. There'll be an evaluation link sent out at the end of the event, and we hope you can take your time to share your thoughts with us. And most importantly, if at any time you need to take a stretch or a break, please do so. We encourage you to take good self-care. Right. And so today, our event over-encompassing title is Community-Based Wellness Across the Age Continuum. And I'm so excited and honored to introduce our first presenter, Dr. Katrina Plamondon, Associate Professor, School of Nursing, Faculty of Health and Social Development, UBC Okanagan, and also a Michael Smith Foundation Health Research Scholar. And the title of the presentation is Resilience is Community Action, Youth-Led Research on the Upstream, Social Ecosystem Determinants of Thriving. Take it away, Katrina.
Thank you, Kim. Technically, I'm still an assistant professor, but maybe that'll be resolved in the next few months because it's under review. But in case anyone is worried about my formal title, it's really delightful to be here. Kim, thank you for that nice opening. It's good to start in such a lovely way. And I'm happy to be with you. I'm here on behalf of a much broader team, and will do my best to share with you a little bit of a taste of some of the work we're doing with our Clarity research team, and I'll tell you a bit more about that in a moment. I'm using 2 screens, so as I turn to my side, I'm looking at my slides so I can stay on track, and then I'll just look back just in case people are curious about that too. So I'm also joining from the traditional and unceded territory of the Syilx people. I'm in Kelowna right now at the Landmark buildings watching a very large storm roll in. So I'm not sure if others are joining from close by, but our skies are always quite remarkable and gorgeous here. So this is the picture of the lake that I walk by just near my house, and I'm always also similarly very grateful. I grew up in this area, and so I've been here for a very long time, and I love that I get to live here. I also want to acknowledge our very expansive research team that's involved in this project. Our acronym is CLARITY, which stands for Community-Led Action for Resiliency Important Throughout Youth. But we never say that whole acronym. In fact, most of us stumble over it. We just say CLARITY. So the CLARITY project is a long-term research partnership with community, with the health authority, with a wide range of community partners. We are able to offer the program and research that we do because of the generosity of funders like the Blank Family Fund and the KGH Foundation, Interior Health, UBC, and also research funding dollars, which are featured here. We have a really dynamic advisory team that's made up of community providers, service providers, advocates, people who come together because they care about providing services for young people and see investing and supporting and amplifying the voices of youth as central to the work that they're doing. And we also have a lot of young people who are part of our research team, either as graduate students, trainees, or ambassadors, or advisors, and a few of them are named there at the bottom: Shahir, Josh, Logan, Maven, and Mia. So I'm going to share with you the results of one of our research studies today, which is a deliberative dialogue study. But before I do, I thought it's important and good to start by clarifying some of the assumptions and things that guide our work in the CLARITY project and in the Equity Science Lab overall. I co-direct the Equity Science Lab with Dr. Sana Shram. Sana and I co-lead the CLARITY project, and we also co-lead and publish and talk about and give trainings and workshops about how we center equity in the work that we do. And so I would offer just a few highlights from that because it really characterizes the way that we approach this work and why we think it's so important. So the first I will offer here is a lot of times we hear people talking about equity. We hear, equity commitments, equity, diversity, inclusion commitments. They're really popular these days, which I want to both celebrate and also challenge, because sometimes those words come without a lot of context or without pausing to define what we mean by them. And equity in particular is offered often without a definition. So here's how we define equity, at least as a starting place. So we define it in 3 ways, and each of these 3 ways requires engagement with the people most burdened and most affected by inequities. So we think about equity as a relational concept, as something that is always a dynamic manifestation of power relationships among people, ideas, institutions. And as an idea, we think about equity as something that is about normative or dominant ideas about justice. And not all ideas about justice or what's fair in the world are the same. These can be quite diverse, but the concept of justice, or the word justice or fairness, is often used without defining what it means, or without pausing to talk about whose voices are more amplified, or what assumptions about justice and fairness are being privileged in a society. We also think equity is an important benchmark. So equity is an aspirational kind of ideal. And the definition that we really like that helps to guide this benchmark comes from the National Collaborating Center for Determinants of Health, which argues about the source of inequities and talks about health equity as being something that we aspire to. It would be a moment in time or a moment in society when, regardless of people's social, geographic, or economic location, they're able to live a full life with dignity. And they also define health inequities in a way that's quite relational to this. So they talk about inequities, and the evidence that we have about inequities talks about them as being systemic, systematic, predictable, and avoidable differences in health outcomes that vary along those same social, geographic, or economic locations in society. Because they are so systematic, and because we know their root causes, we know that these are unearned, and we know they're human caused, and they're therefore actionable. So when we're setting a benchmark about equity, we're talking about recognizing our agency and capacity to intervene on those same things. It gives us something to work towards and aspire towards together. And then really importantly in this work, actually all of these are important, but really importantly, we believe that equity is also an experience. So it's not just an abstract thing that sits sort of away from us. It's lived and felt and embodied. And when people have an experience of equity or inequity, they feel it in their bodies almost instantly. It can happen in a microsecond. It's not always these grand, big, abstract life narrative kinds of experiences. They can happen just in the interaction between people in a moment. And another tool that we use to frame our thinking about equity is that because it is relational and dynamic, we really like to give people tools to help us have good conversations about it. And we like this forest metaphor because when we're talking about issues of youth wellness, and in this context of clarity work, which is really stemming from a desire to invest in youth suicide prevention, we often see inequities manifesting in very real and tragic ways. And the forest metaphor talks about the relationship between all of the things that some things we tend to give a lot of attention to, and some things we give less attention to. So if we think about health inequities or the outcomes that we might see at a population level, if we use this forest metaphor, we can think about that as having to do with the leaves and foliage, the branches, things that we would see visibly up in a forest canopy as we walk into it. These are things that we would talk about as observable, measurable population health outcomes and opportunities. The trunks and branches that we might see in a forest, we talk about those as the bidirectional things that connect determinants with outcomes. And then in the health sciences, we're getting very good now at talking about social determinants of health. We think about these as the kind of craggly, rooty bits that you can feel and walk upon. These are the conditions of daily life. So the places, the conditions, the circumstances that shape the ways in which people navigate their day-to-day lives. And then if you're in a forest, you know that deep down underneath your feet, there are things happening that we can't always see immediately, but we know they are there. We talk about those soil systems, the root systems. These we think about as the structural, political, and commercial determinants of health. They are things like the legacies of colonization, the forces of political economy, things that have to do with governance that aren't always immediately visible, but are there and actually are interacting and giving rise to these other outcomes. And then in the health sciences, the piece that we argue is not often talked about are the determinants of equity, which actually shape the climate system that interacts with and feeds this forest. And a healthy, thriving forest needs a climate system that offers it all of the sunshine and rain and all of the things that we need in order for that forest to thrive. And it's this area that the work I'm going to talk to you today is trying to intervene on. It's trying to intervene on determinants of equity, which we think about as the flows of essential resources. And in this metaphor, those flows are powerful ideas and systems of thought. It is ideas about the world, our worldview, that actually give rise to the structural determinants of health and are what drive and fuel whether processes of colonization and their legacies continue to have negative impacts versus whether we can intervene on those through transforming our ideas and systems of thought. Anyways, I'm going to stop rambling about that and go on to now a little bit more about our clarity work. So clarity really is a long-standing, we've been running for now about 8 years, and the focus on youth mental health really arose from a desire for community to come around and collaborate together in new ways to think about suicide prevention. And this was sparked in part by tragic loss among a local family, and also because we know that young people are navigating increasingly complex mental health challenges. We know that mental illnesses and suicidality disproportionately impacts those who are most burdened by inequities and who are navigating multiple intersecting systems of exclusion or systemic disadvantage. We know that investing in young people's wellness is essential for our collective futures. And we know that by bringing people together who have this shared desire and interest in supporting youth, we really could do something different. We could do something that might shift the needle a little on how we respond to and support young people in our communities. We also knew that there was quite a lot of research available about youth suicide prevention, but we were concerned about the focus on individuals and downstream sort of reactive responses. Because of the nature of this particular issue, waiting until it's downstream can often be too late. So there is a need for a more universal, broad way of thinking about how can we balance that reactive, responsive support that's available to youth and families in crisis with supports that actually prevent the possibility or prevent and promote wellness and thriving and resilience much further upstream. So here's a little bit about our work. I didn't update the year on this slide, but we're continuing to do work. I'll tell you a tiny bit about it. We started with some literature reviews. We really were interested in what evidence was available about the concept and notion of resilience in youth suicide prevention. We held a deliberative dialogue study and then followed up from that. I'm going to share the results of that with you today. We've done a lot of engagement and really tried to find new ways to center young people at the fore of what we're doing and shaping new ways of structuring a governance model that puts youth voices at the center of everything we do, so that the kinds of research, the kinds of community activities, the kinds of events that we do in response to what we're learning are all led by youth. We held a World Cafe, which I'll speak to very briefly today. We have a lot of evolving partnerships. We've established a regional Okanagan Youth Council, and they run regular Clarity events, so we have a sort of branch that is about community engagement and service, and then we have a complementary branch that is more about service or about research. So when we looked at the literature, this is one of the first things we did. And if you scan that QR code, you should be able to access our article about this. There's a lot of work being done about this concept of resilience in the youth suicide prevention literature. And really consistently, no matter what kind of research is done and actually all around the world, researchers argue that there are two kinds of elements of things that contribute to youth resilience. Some of them have to do with what within an individual are their individual assets or strengths, or some folks like Unger talks about ruggedness. And then there's things that are happening out externally that have to do with the supports and resources that are available to them. And although this is consistently found in virtually every study we could look at, this idea that there's something external and about the community is left in a very vague way. So the individual work, things about supporting individuals' coping skills, in intervening on their sense of self and their sense of self-appraisal, or supporting hope, even interventions that acknowledge the relationship between external environments and these individual traits or characteristics, really leave that external environment extraordinarily vague, and most research studies conclude that more work is needed. But then there's very little available to talk about. What is that more work, or what is it about social support systems or the external environments that actually sit in relationship to youth wellness, mental health, and resilience? And so one of the things we did was design a deliberative dialogue study to respond to that. We really wanted to hear from young people about what their ideas were about these concepts that were left so vague in the literature. So deliberative dialogue is a particular way of bringing people together, convening people in a dialogue kind of setting. It can feel a bit like a workshop or an interactive conversation. It's used in both research and depending on what term is most comfortable for you these days, it's changed a little bit, but sometimes we've said knowledge translation or knowledge mobilization method, but it's a way of bringing people together to talk about evidence in context of their experience, in context of their community. It's a very facilitated and structured kind of conversation, and it's always future facing. So the point of it is to talk about the implications of some body of knowledge or some body of evidence and ask people, what do they think this needs? What does this offer for us in terms of direction? How does it help us understand something with greater depth? How does it direct what we might do together about it? In this instance, we were really interested in extending this sort of vague notion of resilience having something to do with community into something that was actually more concrete and gave us direction to respond to either do other research or to design more community interventions that actually fit with how young people understand what community-based or upstream resilience might look like or feel like. A deliberative dialogue can involve all sorts of people, depending on the purpose of it. So our dialogue had a particular mix of perspectives, but really, when you're planning for deliberative dialogue, it's very important to think about issues of power dynamics, how you're going to balance perspectives, who you're going to bring in, and how you're going to be accountable to the people who you're inviting to share their time and energy and vulnerability with you in that dialogue space. So in our case, in these dialogues for clarity, we were really interested in young people and the adults who are caring and provide support in their lives, either because of their individual and personal connection to young people, or because they're service providers or community advocates who are interested in the same kinds of things that we were. And so we sought out folks who identified as having, young people who identified as having navigated some sort of difficulty in life, but remained hopeful or optimistic about the future. And we really were clear that that the Clarity Project was coming at this question from an interest in youth suicide prevention. The question we put forward, and this is really what attracted people to come and talk to us, was what do resilience promoting communities look like and feel like? And we had a really positive response. So we held 4 different dialogues and 31 people contributed to these dialogues over that stretch of about 6 months. I think we ran these over about 6 months. One dialogue involved school-aged youth, one emerging adults, one we held with caring adults, and another with community service providers. And then we had a community validation of what we'd heard in the dialogues that involved about 75 people from all of those groups all together in one room. Some of you may have been with us for one or more of those events. And to be clear, each of these, we chose to run the school-aged youth, emerging adults, caring adults, and service providers dialogues separately because of our considerations of power and what we thought would make for the best balance of perspectives while also thinking about the needs of people in those dialogues. So I'm going to just share with you now a little bit about what we heard. In the first dialogue we held, which was with emerging adults, we had this beautiful offering of, and I apologize for anyone who speaks Japanese fluently because I'm probably not going to say this correctly, but kintsugi as a metaphor. So kintsugi is a practice of mending broken pottery with gold. And one of the young people in the dialogue offered this as a metaphor. We had invited people to think about creating a piece of artwork or collage as a starting place. And they shared this artwork they made. They just showed an image of this pottery mended with gold as a starting place for their reflection on what community resilience looked like. And they shared it because they said, as an art, it literally requires many hands to hold this together and to create something beautiful and strengthened out of things that have had fragility to them, and things that felt like they'd fallen apart, but actually there's so much beauty resting in them, and that by bringing it together and mending with gold and support, having many hands support this together, something quite beautiful and stunning comes out of it, something that's actually stronger than it was from before. And this prompted quite a beautiful and rich dialogue that many of the emerging adults in that conversation agreed with, and others responded by saying, yes, it's amazing, it's how beautiful it is to have many hands help you put back together and be stronger than before. And others, this really expanded this conversation about how resilience isn't just something that is an individual experience. It's not possible without the care and love of others, and that really it requires many people coming together. And when we brought this idea into the next conversation with school-aged youth, and they asked them, what do you think about this idea about resilience happening as a result of many people coming together, or about an experience of support? One of the young people offered, I feel like resiliency isn't just a phrase. It's something that it's not just something that you can say and be done with and stuff. It's like resiliency is more of a continuous group effort. It's an action that everyone takes together. So as they continued these conversations, and across all 4 dialogues, we would offer some of the insights that emerged in one dialogue and use those as prompts for conversation. And 3 clear concepts emerged, each of which were mutually influential and reinforcing. So we heard people talking about belonging, connection, and social climate. And belonging had something to do with a felt sense of knowing that you were part of something, a member, that there was some sort of explicit warmth and welcome, and that you belonged in a place. Connection was we heard this as having something to do with the active interaction with others. So you could connect with others without having that felt sense of belonging. So interaction can happen in many ways in many places, but whether that connection is a positive experience or resiliency promoting experience or not was dependent on these other 2 concepts. And social climate, we heard about that being the prevailing conditions within a geographic region, or sometimes a social climate in a digital space, so in social media. It has to do with the sentiments and signals that are shared and that create the tone of the place that young people are interacting with. And they talked about resilience as an act of cultivating a positive experience of all 3 of these things. And when it came to belonging, young people actually, and caring adults and service providers, all talked about the importance of belonging. They all craved it, desired it, and thought it was really central to their own wellness, and also to their capacity to support and engage in resilience promotion with others. They talked about this as involving finding your people, being able to be seen and understood. And in contrast, sometimes we heard people talk about feeling like places where belonging was absent. They used words like they're full of vultures, or they used like very graphic kind of imagery to talk about how an absence of belonging felt hostile and really threatened their sense of wellness. They saw this as being signaled to them in place, language, and opportunity. And so, for example, simple things like signals of welcome stickers, rainbow stickers on doors, signaled you are welcome here. Sometimes it was an explicit communication of belonging. So the ways in which a caring adult or an adult in a student's, so for one example was in a high school, or in a university classroom, having the grown-up or the adult in that space explicitly showing and checking in with young people were some of the signals that were communicated in place about you belong here and we care about you. They talked about this as being present when they felt like a where cohesion was possible, vulnerability was possible, and relationship was possible. So all these things were sort of found in places where cultivating belonging was actively happening. They said it feels like being seen and valued and important to others, especially across generations. So young people wanted to interact with and belong in places where not just youth were there. They didn't want to be siloed off. And similarly, caring adults expressed the same kinds of sentiments. They didn't want to feel siloed off. And there was a general concern about the fragmentation of different cohorts of ages, as though belonging can only happen in age groups, when actually people's desire for belonging spans across generations. And another really clear sentiment was knowing that belonging happens in places where you know you have a soft place to land, or a place where warmth and universal welcome, where you know that it's going to be available to you without having to qualify for it. When it came to resilience as an act of cultivating connection, this sat actively in relationship with belonging, but was a bit distinct. So connecting and experiencing belonging was what people thought mattered most. And a lot of young people wanted this kind of connection to happen in person as well as online. So not to exclude one or the other. A lot of caring adults were really concerned about the kinds of connections that were happening online. Young people were less concerned about this, but they were really adamant that it wasn't enough to be exclusively connecting with others online. And they really grieved the kinds of impacts that COVID had on their ability to connect with others in person. They said that connection with belonging feels really authentic, and it allows moments of interaction about real issues that they care about. So they didn't want to be dismissed and have only superficial kinds of interactions and connections. They wanted to be able to connect and talk about real societal issues and come up with solutions and feel like those solutions were going to be valued, heard, and taken up by others around them. They also thought that connection had to happen in places where you know that you could just be, and you could share struggles and clear minds and sort of not feel alone in the burden of whatever it was that you were navigating. And so across all 4 dialogues, especially amongst the adults, the caring adults and service providers talked about points of connection needing to happen in many places, so that the ways in which young people were navigating their daily lives offered many points of interaction with many caring people. It wasn't going to be only at school or only at in one kind of exclusive event. It had to be many layered. And so this really got us thinking about how can community come together to really support each other and make and harmonize these efforts, because many people want to offer that, but they're often fragmented or siloed. Or maybe they're under-resourced, or if people want to talk more about that, I haven't included much content on that, but we really did unpack that a lot, especially in our World Cafe. And then finally, resilience as an act of cultivating a positive social climate. In all 4 dialogues, people talked a lot about how the social climate around them really affects young people and the caring adults in their lives. And this includes exposures to signals of who belongs. So it's public, it's not necessarily, for example, racism directed at an individual on an interpersonal interaction, although that is harmful and people shared experiences of that. They talked about the vicarious and sort of general climate of just witnessing it or hearing it on the news or seeing billboards that convey signals of welcome or unwelcome. So all of these sort of sometimes taken for granted ways in which a community signals and invests in celebrating diversity and invests in celebrating and countering communication that would otherwise serve to exclude particular groups. And when they said a positive social climate was present, they talked about this as making belonging possible. making hope possible, making the idea of connection more meaningful, and really something that honored diversity and celebrated it. So altogether, we have the results of these deliberative dialogues are now under review in a manuscript with Critical Public Health. And we think that the ways in which these three concepts extend the conceptualization of resilience are really helpful starting points for talking about community as experience and not just geography or not just place or something that our identity connects us to. It's actually something that we need to interact with and actively engage in. It opens a conversation, and we have some thoughts about how it sits in relationship to ideas about solidarity. It's starting to shape a broader conversation about data that goes beyond individual outcomes. And we have some research, some really exciting arts-based child and youth-led research about building on these concepts to really broaden the kinds of data systems and structures that are used to monitor youth wellness, mental health, and resiliency. And we're starting to build a more robust vocabulary that reconciles the dissonance between evidence and action and fills that vague gap with something more precise and more specific. I'll just very briefly share that we've really worked on advancing equity through clarity, continuing to do so through the research that we do. And we've really built a responsive community programming that complements all of the work that we're doing. So you can find us on Instagram. There are an amazing group of young people who are leading community initiatives, activities on a regular basis that are all doing the same, this resilience promotion, cultivation through connection, belonging, and place. So we're actively applying what we've learned through our community programming. And here's just a few photos of some of the events. We have some amazing folks. Josh leads a lot of our community engagement. There's an incredible Dungeons and Dragons night. We've had movie nights, all sorts of mental health cafes, hiking activities, all sorts of things are going on. And I just want to put a shout out to the young people who make this possible, who step up and use their voice to call community into these activities. And I really, and at another event, we can share more, and they can be the ones speaking to this. They often do speak to it at panels and things when we are we're talking about clarity work. You can find a little bit more about reports from our World Cafe are available on the Blank Family Fund website, and more on our Equity Science website through our Instagram. And if you'd like to connect with us, please send us a note. We are really excited to keep seeing how clarity will continue to unfold. So with that, I'll stop sharing and open it up for some questions and conversation.
Thanks so much, Katrina. And yeah, please feel free, attendees, to put your question into the chat. I'd be happy to read it over for Katrina. And I can start the conversation off with what's your role to support these this youth-led community events? So what is your role in that? What does that look like?
What does my personal role look like? I don't go.
No, I meant like
I'm too old. So my role, Sana and I, what our role is we leverage our research platform to find funding for these events, and we provide mentorship and support. We've supported, for example, establishing the partnership charter that guides how they engage. We think through issues of insurance and liability and transportation, and we provide the administrative support. So we provide a lot of background support, but we don't direct it. We hear, here are our 5 things we'd like to do, and this is the resourcing we need, and here's the demand and interest, this is how much budget we need, and then then San and I go and try and do whatever we can to find resourcing to make that possible. So it is a constant effort. We build the Clarity youth engagement and roles for youth ambassadors. So we build funding in for jobs and for honoraria so that young people are always compensated for their time if they're contributing to consultation or dialogue. If they're participating in an event, we make sure that it doesn't cost them anything, that they have access to transportation or whatever resources they need in order to get there. And yeah, so that's the short of what we do. We're always looking for ways to continue to support because the demand far exceeds what we can keep up with. So really, it's become a lifeline for a lot of young people in community. They come to these events and find support. They find a place where they belong and are accepted. And for a lot of them, it's really become central to their wellness.
Well, thank you. And thank you for that too. I think that makes good sense. Being like the foundational support of just whatever they want to make happen, you're just there to provide the boost up. So in the very beginning, you had the beautiful slide which showed all the different areas and the climate systems with the determinants of equity. And I made so many notes on that I'm actually having a hard time reading them because I was so excited when I saw that slide. But for as a generalized question, how would you suggest someone start when it comes to thinking about embedding health equity into their work or integrating health equity into their work? What would you suggest would be a good starting point?
Such a good question. And we actually have a little handout. I can maybe make this available. I have a 5 good equity practices. I don't know if it looks backwards in your screen, but it's backwards in mine.
It's not backwards in mine.
So I can share this with folks. And so we've thought a lot about how do we start really good conversations? The Equity Science Lab has a few resources that are really designed to be accessible kind of across many sectors and settings, plain language kind of ways of talking about how we embed equity in our work. And we have a framework called the Ripple Effects Framework. So I don't know if I can put this in a chat box, but I'll share it with you in a second here, Kim, just a link so folks can find it. So I think that that framework is a really good resource if people want to dive in a little bit more deeply. We have one on equity considerations in planning participation, which is a workbook kind of style tool that can help people ask really good equity questions. And then I have, I really believe there's 5 basic equity practices that anybody anywhere can do. And they start with recognizing your own role and responsibility. So seeing that equity work is something that all of us anywhere can take up in anything we're doing. So even starting there and recognizing that maybe I've got some reading to do, or maybe I've got some learning or unlearning to do. That's a bit of personal work in that. And then there's a bit of thinking really carefully about what is my position in the world and what is my job and how does it intersect with others, and what does that mean for my, where does equity show up or could it show up? So some of that is mapping out our positionality, not so much in terms of my identity, that who I am and where I come from absolutely affects how I understand the world. But the other part of positionality I really invite people to pay attention to is the position they hold and the influence it carries. So you, Kim, in your role have this beautiful wide reach to all these people, and the ways in which you communicate are part of your sphere of influence, and you make equity choices in those communications. So that's one example. The next is to unpack influential worldviews. So to pause and think about the assumptions and the things that we take for granted. So in the clarity work I just shared, the worldviews that shape assumptions about resilience, for example. A lot of times we think about resilience as something to celebrate someone's tenacity in making it through something hard, but maybe we ought to challenge the worldview that says hardship is inevitable and we ought to celebrate people surviving it. Maybe we ought to reduce the risk of so much trauma just from living, from navigating a hostile world. Then get clear about equity and its determinants. align intentions with action, and align actions with evidence. Those are the 5 things. So I'll share this 5 good equity practices with you, and you can share it with folks if they're interested.
Thanks so much. Yeah, I would be happy to. And I know we're at time, but we do have one question in the Q&A. So I feel like it's okay, considering I had my my intro in the beginning. I feel like you're with that extra minute or two. So Lisa asked, how receptive have you found youth to be in? I'm assuming she means participating in research. Any gems of feedback or lessons learned have youth provided that you would use for future engagement of youth in research?
Such a good question. So we find that appetite for engagement is extraordinary. Young people want to be involved. What we hear is, and what there's good literature about and calls for, is that young people are often excluded from research and decisions that are about them, but they have a lot of really valuable things to say. And what we hear consistently is that we don't want to just be tokenized. We want to be listened to and taken seriously because we have good ideas, and we want to be central to the governance structure. So we've thought really hard about how do we structure something within clarity that allows that to be possible. And we find young people, we are never short of folks who step up to participate in the work that we're doing. Certainly could talk more about that if anyone is interested. We can follow up offline, but yeah, huge appetite, lots of enthusiasm, lots of brilliant ideas, and desire to be involved. Yeah.
Well, thank you so much for your time and for your sharing of all of this, Katrina. I thoroughly enjoyed all of it, and I appreciate so much you taking the time to share that with us. And I'll wait the pamphlet, and I'll make sure to share it with everybody that's registered for today, if that's all right.
Yeah, no problem. I'll put, I think I can just put it to the host and panelists in the chat box. I'll send a link there.
Sounds great. Well, thank you so much.
Thank you for having me.
All right, and I'm going to introduce our next speaker. There we go. This takes me a minute for all the shuffle. So it's a pleasure to introduce Adriane Peak, Research Assistant, School of Nursing Faculty of Health and Social Development with UBC Okanagan. And her presentation is going to be on mental health conversations. Take it away, Adriane.
Thank you so much. And I just want to say I was more than happy to share any amount of time with Katrina and her work. It's been making me so happy to see all of these similarities between our work. So I will carry on with the conversation about conversations. So welcome everybody. My name is Adriane Peak. I am a graduate of the Interdisciplinary Graduate Studies program at UBCO in the Community Engagement, Social Change, and Equity. I will. There we go. Okay, so I am the research assistant on this project to Dr. Nellie Olkey at the School of Nursing in the Faculty of Health and Social Development at UBCO, and I'm presenting on behalf of the whole team at SC Health, University of Waterloo, and St. Francis Xavier. I'd also like to take a moment to respectfully acknowledge the Syilx Okanagan Nation, as well as the traditional territory of the Osoyoos, Lower Similkameen, Upper Similkameen, and Penticton Indian bands that we've been conducting this work. It's been conducted on many ancestral unceded territories across Canada, and we're all joining today from many places. And I encourage you to explore and reflect on which Indigenous lands you live and work, and be sure to acknowledge the traditional Indigenous owners and caretakers of those lands. So to begin, what exactly has motivated this multi-phase project? The healthcare system focuses on physical needs, which creates missed opportunities for integrating mental health support, care, and treatment. There are many challenges to accessing mental health support. Some challenges that older adults specifically face is the dual stigmas of systemic ageism and negative attitudes towards mental health, which can impede help-seeking behaviors, resulting in unmet mental health needs that are often underreported or misdiagnosed. We found that home and community care providers are very well positioned to support mental health conversations, but we're needing to build the capacity of that workforce to do so, which leads me to the goal of this project was to co-design and test an evidence-informed approach to starting mental health conversations between health and social care providers and older adults and their caregivers in home and community care settings. To begin development of an evidence-informed resource to support mental health conversations in home and community care, we began this multi-phase study that aimed to co-design and test. This study uses the Participatory Research to Action framework, which was developed at SE Health to engage experts by experience, such as patients, caregivers, and other knowledge users in health services research. Our most recent research protocol paper can be accessed with the QR code at the bottom there. The Participatory Research to Action framework brings together concepts from service design, co-design, and integrated knowledge translation to articulate a process for participatory applied health services research. Phase 1 focused on adapting a visual mental health model called the Mental Health Continuum model that provides a visual representation of what mental health is and adapted this for an aging-focused home and community care context. In Phase 2, we co-designed mental health conversation processes and approaches with community-based health and social care providers using this model. In Phase 3, we intend to evaluate the implementation of the co-designed and evidence-based mental health conversations at the point of care to assess feasibility and preliminary outcomes. A note that we have been, throughout this study, we have worked with a group of experts by experience across Canada to help guide study design and conduct, like supporting recruitment and supporting knowledge mobilization. So Phase 1, we engaged Canadians from all 10 provinces and 3 territories in Canada to create the adapted model, starting with 4 online workshops with older adults, caregivers, and health and social care providers for feedback on the model adaptations needed. We then created the adapted model and presented it in an online survey. The goal for our first phase was to adapt and validate the model, and to do so intentionally for use in an aging-focused home and community care context. We conducted the 4 online workshops to adapt and then validated it using an online survey with over 1,000 respondents. So to show you the changes that were made to the model, I'll start with this slide here shows you the difference between the two, where we started on the left, which was developed by the Department of National Defence for the Canadian Armed Forces. It has been used among students, first responders, etc. The mental health continuum for aging Canadians on the right-hand side is the adapted model. It incorporates more inclusive language, colors, and concepts. I will describe more in the next slides. In the original continuum, there are 4 levels of well-being, and the color spectrum is green, yellow, orange, and red. As well, there are 6 categories: mood, attitude and performance, sleep, physical symptoms, social behavior, and alcohol and gambling. When we asked our survey respondents to how the model could be adapted to support mental health conversations with aging Canadians, changes were made such as improving the use of action-oriented language across the model, the more inclusive use of color, the element of capturing change over time, removing a lot of clinical jargon and diagnostic or stigmatizing labels, and revising and adding signs and signals to be more context relevant. The context we designed is meant to be discipline agnostic, so it is usable across health disciplines and to act as a non-diagnostic, non-clinical resource to help support destigmatizing conversations about mental health. It can be used to help people understand that mental health is a dynamic spectrum that can change with many different components. For example, thoughts and feelings, sleep, and physical health, and signs and signals that can be looked at to consider where someone is on the spectrum. So at the bottom right, you can use the QR code to access the model itself. And I do have a larger view for you. The QR code is on the bottom right again there. So the 6 new categories are thoughts, feelings, and emotions, daily routine and activities, sleep experience, physical observations, relationships, participation and connection, and habits and coping strategies. The 4 new mental well-being indicators across the top are all good, take notice, find support, and seek care. You will also see the guiding information below that a caregiver or an older adult can use to decide if they may benefit from seeking engagement with other supports. There's also the 2-way arrow indicator below that is also a helpful tool for gauging mental well-being over time, asking if there has been a change from the usual, if the behaviors have become a pattern, and if those behaviors are becoming a concern. For phase 2 of the project, we wanted to co-design additional resources and processes based on the model to support our home and community care providers to use the model. We have been working with 15 different home and community care organizations across 3 provinces in both urban and rural communities. Shown here are the demographics for our sample of providers, and please note that these characteristics are reflective of the Canadian healthcare workers as a female-dominated and aging workforce. We hosted 7 very fun workshops in the 3 provinces, and in each of these, in each of these, we engaged participants in making and actioning work by using activities to help them move beyond explicit surface level ideas or responses, and instead helping people tap into the creative, messy, innate process that generates some unique and innovative solutions. We did this in an iterative way by having participants in small groups first generate their best idea for what the model could look like, create a script for using it, and then actually act that script out and ultimately reflect on the different skits and ideas. We compiled artifacts like the ones in the images here and paired them with audio recordings of the workshops to conduct a framework analysis to generate ideas regarding the different components that would be needed to support our care providers. We refer to what we have developed as the Mental Health Conversations Initiative. The initiative has 5 components. The first is an implementation framework, which is a resource with information about different factors health and social care organizations should consider if they want to implement the Mental Health Conversations Initiative. The framework will have key messages to support change leadership or talking about the initiative with other leaders within the organization. For example, why these conversations matter to value-based care, how it can support a post-COVID resiliency and advance workforce stabilization efforts. There will be information about what needs to be in place at the organization and the point of care to be able to implement the initiative, which includes the need for training for care providers, which is the next element. We will also include in this training from the phase 2 workshops messages from care providers themselves to show the value and benefits providers see in the initiative. The next element we will develop is based on phase 2 feedback as well, and is a conversation guide that can support providers to prepare for and conduct these conversations. The idea is that this resource provide guidance, but also recognizes and leverages care providers' existing skills and knowledge to support them to have these conversations. We plan on making a long and short version of the guide, with the short form acting more as a quick reference care providers could use before going to see their client. The long version will contain a decision tree with information about how to use the guide, guiding principles that providers should keep in mind during mental health conversations, for example, empathy and creating a safe space. There will be information about each step in the conversation process, such as preparing to have a mental health conversation and thinking about when a good or a bad time might be. There will be prompts that can be used to start the conversation and tips on how to navigate. There will also be some actions to take post-conversation. For example, whether you have asked the client to do something before the next visit, or if the provider should speak with their supervisor about their client's mental health support needs. The last component, aside from the conversations themselves, is a mental health conversations toolkit. It will contain resources for providers, older adults, and caregivers to support the conversation. The workshops provided many ideas, as you can see here, regarding the format of toolkit resources and their key functions, such as creating a calendar that can hang on the fridge, a giant fridge magnet, the living toolkit, such as a plant, paper booklets, podcasts, notebooks, and to support functions such as having a visual reference, educating about mental health, tracking mental health over time, fostering communication, and facilitating self-reflection. To find the best mix of toolkit formats that also meet the functional needs, we're currently working with a service design company called J5 to develop concrete prototypes of toolkit resources that we will use in the next phase of the study. I apologize for this graphic. It's hard to cram all of the great ideas that we've started with. There's about 30, as I said, and so there's 3 general categories that we're working on: tracking and self-reflection tools, conversation support tools, and information and educational tools. These ideas will be continued to be refined and narrowed down based on feedback from the working group and from the collaborating organizations to ensure that they provide the intended impact and are useful for the people who will ultimately use them. Some of the resources will stay with clients in their homes, whereas some others may travel just with the care providers. Phase 3 has been planned with feedback from the working group on the surveys and interview guides, and we will use to continue to explore the acceptability of the initiative, the feasibility of implementing it in practice, and whether it actually leads to changes in outcomes among older adults and care providers, such as changes to mental health knowledge. The key takeaway that I want to leave you with is that we believe in producing and realizing evidence-informed approaches to mental health conversations is one achievable way to help create a shared understanding of mental health and destigmatize mental health in a discipline-agnostic and non-diagnostic way, and to build capacity for providing mental health support to aging Canadians. And so if you have any questions at all, I'm happy to answer them here, or you can always contact Dr. Nellie Olkey, who is the co-investigator for this project in British Columbia, or myself through these email addresses here. Again, the QR codes for the protocol and the Continuum model itself are there for your enjoyment. And also, if you'd like to see any of the other projects that SC Health is working on, you can use the left QR code there. Thank you.
Thank you so much, Adriane. That's awesome. And feel free, everyone, to please put any questions into either the Q&A box or the chat box. I have my eyes peeled for both. And oh, there we go. I'll put me alongside with you, so then I don't sound just like an overarching voice. I'm very aware that sometimes I do that. I made a lot of notes as we went along because I feel like there's so much promise for this spreading out into so many different areas. And I feel like it's very timely, given that we do have an older aging population. And from my past experience, especially thinking of my dad being a bit older, and how mental health is a conversation that I think it takes a little bit longer to get there. So I think that our care providers having that conversation is such a valuable place to create that safe space to start. So we have a question from Juanita, who asks, can you please provide the research protocol reference for the article?
Oh, did you want me to just share that screen again with the QR code? Or I think I have a slide with references as well. Let's see here. Um, the protocol, I believe, is number 6. Or is the QR code easier?
Juanita says reference is great. Thanks.
Okay.
Thanks, Juanita. I wonder, as you went along with this project, and I know you have Nellie, who's an implementation scientist, that's there along the journey. So you have quite a unique and beautiful integration of that in, I'm sure, with the work. But from your perspective, was there anything that was, most surprising or most, enlightening as you moved along?
I have been asked this before. I guess maybe strangely the most surprising was the excitement and willingness of every care provider that we talked to about developing something like this. A lot of people are afraid of like kind of delving into that clinical side of things, but they were thrown into these conversations during their work and didn't have anything to support them. So we're trying to sort of get a little bit of both sides in this project, is the support of a non-diagnostic, non-clinical resource that they can use that's solid and has helpful, useful information, but also integrate it with the more natural side of having a conversation. These care providers aren't people that have any sort of mental health training. That was actually a stipulation of being a part of the project, that we didn't want. We were looking more towards the people that go into the homes to give the baths and manicures and help them with food and errands and things like that. So it was really great to see how exciting, or sort of how excited everybody was to act it out and do the little plays and really envision using something like this. And then the most common question was like, can I take it with me? I want to use it right now. I'm going to go like later today. I have an appointment. I want to try it. And so it's really great to see how accepted it was.
And that's awesome, because that was actually one of my other questions too, is for the care providers, like for lack of a better term, like the buy-in, like how eager and connected they were to it, or if there was any resistance. And I'm hearing that there wasn't at all, that everybody was like, we're all in, whatever we can do to be of support. And noting that, yeah, exactly that, that the background in mental health supports might not be strong, but everybody wants to be of use and of help. That's awesome. Just make sure I didn't miss anything in the Q&A there. Oh, shoot. And while I checked, I forgot my question. Hang on, it'll come back to me. Happens to me often. Oh, yes. So you spoke about a phase 3, like so the next phase. Oh, this is what I was going to ask first. So the connection between, for the care provider having kind of like that toolkit and those, those supportive kind of prompts. And then I wondered about the connection from that to kind of that everybody connection. So you mentioned in the second piece, there was the plant and all those ways, and the magnet for the fridge, and kind of like, I wondered if how that connector line goes between the one to the other, if that makes sense.
I think where I started thinking about was another, maybe not so surprising, but another comment that was often made was, I can use this for myself, like even asking myself these questions. And so our intention was for to be more of an aging community context, but everyone who was using it thought to themselves, I mean, the family and friends could use this as well, as they're, talking it over with their mother, father, whatever, they might recognize some signs and symptoms in themselves. And so the applicability across groups is actually wider than what we expected. And then to tie in other forms of using it, such as, well, I'd have to say that the plant has probably not been as accepted as the other ideas. The idea was to give the client a plant and then talk about the plant over time, like watering, and like, have you watered the plant today? And somebody immediately always says, well, what if the plant dies? So it's not, we want to provide resources that will last and that are applicable over a longer period of time, perhaps, and easy to do, easy to take care of, because the most popular is, say, a calendar or a giant like fridge magnet that can go on the fridge. And then you have sort of your little indicators of where am I today that you can put on it, and just to track your emotions, your feelings, and your signs and signals.
Very cool. Yeah. And I get that with the plant. I wondered if I don't have green thumb at all. My daughter has plants. I do not have plants.
Yeah.
Yeah, I do my best to support her with the plant journey, and then, and then I step back. But I love that, and I do love magnets too. I have a plethora of magnets on my fridge, and I think that that's a very smart thing. And somewhere you're always going to go to the fridge, so that's like that repetitious. So my last and final question, because I haven't seen any come through. My team, please let me know if I missed anything. Is what are you most excited for the next steps? Because I know that there's another phase. I know that there's more work to come. What are you most excited about or most interested in to explore next?
I am really excited to see where the actual ideas go, what we can actually produce as a tangible offering for these people, and to see them use it and to hear their stories, because a lot of the time through this work, you don't get the feedback after the fact. You kind of put something out there in the world and it goes where it goes when you write a paper or what have you. But something like this, I'm really looking forward to continuously talking with these care providers and keeping that relationship open and hearing about the improvements.
That's awesome. Well, we look forward to hearing what happens next, and we welcome you back next year to share with where you're at. And thank you so much for your time and for sharing all these learnings. And I'm so my heart is so full knowing that you know that this work is out there, because that's important. So thank you.
It is. Thank you for having me.
Okay. There we go. Sorry, I have to push a whole bunch of buttons in the background. Okay, I'm going to introduce our next speaker. And I'm just going to spotlight. Oh, I can't spotlight until after I introduce. So up next is Dr. Juanita-Dawne Bacsu. She is the Canada Research Chair Tier 2 in Nursing and Population Health, Assistant Professor at School of Nursing at TRU. And the presentation today is titled Population Health and Aging Rural Research, PHARR Center, Improving the Health Equity of Rural Older Adults. Take it away, Juanita. Oh, I just don't see you. Hang on. I'm going to remove my spotlight. There we go. You are spotlit. You're good to go. Thanks so much.
Excellent. Thanks so much for the introduction. So I am Dr. Juanita-Dawne Bacsu, a Canada Research Chair in Nursing and Population Health at Thompson Rivers University. And my presentation today is on our newest research center that just opened on June 14th, 2024. So the Population Health and Aging Rural Research Center, the PHARR Center. All right, so before I get started, I'm just going to open in a good way with a land acknowledgement. So we are located on the Tk'emlúps-te-Secwépemc territory, situated within the unceded ancestral lands of the Secwépemc Nation, where we are privileged to live, work, and play. So here's a brief overview of some of the topics that I'll be covering in the next 30 minutes or so. I'll provide a research journey about myself and how I became kind of fascinated with research. A little bit of overview about my research team. There's no I in teamwork, as we all know with research. some information about the vision of the PHARR Center, our areas of focus for research, and then our next steps for moving forward. All right, so my research journey, oh my goodness, I've been so fortunate. So I've been working at research centers since about 2000, early 2000, yeah. And so it's well over 20 years. And so what an opportunity really to get paid to do what you love and do research. Aside from that, I also had the opportunity to work as a senior communications manager with the provincial government. I co-owned a medical clinic, and I was a television segment host. And so I feel that all these different opportunities, they were so important, not only when I think about my positionality, but also the lens that I bring as a researcher. When I conduct research, I'm thinking about the policymakers out there. You know, will the government take this up? Do I have to put it into a briefing note? I'm thinking about the practitioners and the physicians at the medical clinics, and what do I need to do to translate my research so that they actually have time to pick that up? And then I think about just as a television segment host and conducting interviews, and how do I get this out to the broader public? How do we share that information? All right, so I've been very fortunate. Right now, I think there's over 50 articles now that we're on in peer-reviewed journals, which is so exciting as a researcher, because you always start out and you're like, wow, you know, you see all these other researchers and you're like, how do you get there? How does this happen? We've published now 6 book chapters. We have almost $5 million in collaborative grant writing over the years. And then as PI, I've gotten over 1 million, 90 plus international conference presentations, and several community presentations. And I love the community work. It really brings meaning to what we do. It's all about the community-based research. My research interests, they really focus on rural and remote aging, cognitive health promotion, and dementia. Over the COVID-19 pandemic, when we were kind of halted a bit, I pivoted and turned into social media and Twitter research. And so that's been a really interesting venue that we've gone into. And then, of course, population health intervention research. Ooh, so why rural? Now, whenever I present at international conferences, I always get comments of, you could easily solve this. These aren't issues. Just put a helipad on top of the hospital and have the helicopter come in, and they can take the older adults out to the hospital in the city. So that's why I think it's so important to provide the context of my research. So when I think about rural, I define it, Statistics Canada provided a great definition. I'm looking at populations that are 10,000 people or less, and that usually the communities that I work in, they have limited access to resources and healthcare services and really dispersed geographies. So putting in a helipad, it's not really an option for most of the rural and remote communities that I'm in. And we do know that rural older adults, they often experience unique challenges, not only related to the limited public transportation and education and finances and the geography, but this limited access to healthcare services. And then we also know that there's higher rates of chronic disease, cognitive impairment, and dementia compared to our urban communities. However, I don't want to focus on the negatives. When I do research, I always think it's so important to use a strength-based approach. And so, you know, there are a lot of challenges in the rural communities that we work with, but there's also great potential and innovation for developing collaborative community-based solutions. So our vision at the PHARR Center is to really focus on enhancing health equity, to support healthy aging and aging in place for rural older adults. And so I was so happy to see Katrina and Adriane's presentations and how they talked about equity and the need to define it. So when I'm talking about health equity, I'm talking about those unfair, avoidable, and unjust differences in health outcomes. So this definition that I really focus in with my research is from Margaret Whitehead in the United Kingdom, and her paper, The Concepts and Principles of Equity and Health. And so that's really foundational to the work that we do at the PHARR Center. So our mission here is to promote community-driven research that's really informed by rural older adults. including people living with dementia and care partners. And then we also conduct population health intervention research to improve rural aging at the individual, community, policy, and societal levels. So I'm all about frameworks. I love frameworks and I love models to help guide the work and the research that we do. Often when we do our work, I use the social ecological model. I love it because it provides different levels that we can target. And that's where I'm bringing in those different hats and the different perspectives that I bring. So I'm thinking about lived experience and people, you know, the older adults in the communities themselves. I'm thinking about the healthcare practitioners and how do I get our research out to them and collaborate with them. And then also I'm thinking about those broader levels at the policy levels and how do we work with our policymakers to support healthy aging in rural communities. All right, so as I mentioned earlier, there's no I in teamwork, and anything we do at the PHARR Center wouldn't be possible without our amazing team. So here at the Inner Center, you'll see a photo of some of our research faculty. We're a very interdisciplinary unit. We have Dr. Wendy Holkel from the Faculty of Education and Social Work at Thompson Rivers. We have Dr. Claudia Gonzalez from the Faculty of Arts. And then we have some nurses, Dr. Melba D'Souza, Dr. Anila Varani, and then we have a faculty member from science, Dr. Mark Rakobochuk. And then on the end, you can see all of our research assistants. And so there's so many on the ends. It's just so important, you know, that we have those connections and those partnerships. And speaking about connections, the work that we do would not be possible without our community partners. And I feel like I only listed a few here. So if I didn't include you, apologies. There are so many amazing team members and organizations that we're so fortunate to collaborate with. And it's just been really incredible, the community support that we've received since we opened. All right, so our research areas. The PHARR Center, we focus on 4 main areas. Rural aging and dementia care. It's so central. There's no time that I go out to a rural community and it doesn't matter what interview for what study we're doing, but dementia always comes up. It's such a huge and growing issue. So that's one of our areas. The other area is cognitive and physical health, navigation of health and social care. It seems like we can never have enough resources out there to support access to care and support services. And then lastly, something that's very close to the work that I do, focusing on stigma and social inclusion, but also exclusion. All right, now our PHARR Center objectives. So we really want to conduct population health research that's informed by interdisciplinary innovation and lived experience to really enhance that health equity of our older adults. We want to foster meaningful partnerships and educational opportunities to really build capacity for our community leaders, students, clinicians, and policymakers. And then lastly, we don't want our research to sit on the shelf. We're all about turning our research into action, so we're working to develop effective knowledge translation strategies. Oh, I love this. All right, so where do we go? This is our liftoff. So this is our activities and our events that are happening, and so what are we up to? So the opening day of our center, we are very fortunate. We were able to host a rural aging and dementia stakeholder forum. So that was great to be able to just bring in different groups and have us all just sit and collaborate and discuss. We've been hosting some thematic analysis workshops, so bringing in some training for students at TRU, which has been really, really cool. And then on more events again, there's always events, right? That's the great part about research and publications and all of that good stuff. And I'm just going to hop over here. If you're on LinkedIn, please join our LinkedIn webpage that we have created. We have a Twitter page account now created and a website. It's kind of amazing when you open a research center, all the different communication venues that you can use to really get the word and the work out that you're doing. We've started a biannual newsletter and then journal articles. We've done some podcasts. And so just a lot of cool things going on. Now, let's see. Here we go. Now I'm going to share a video of a recent event that we held just to give you some more context of some of the work that we've been doing. Can you see my screen still?
Just your PowerPoint.
All right. So I'm going to get our technology going here. We'll go stop share and start share and share. Can you see our screen now? Are we good?
Yep.
Do you
Now
see a
we've got
video?
Yep.
All right, fantastic. So we will close with our video. All right. Oops.
We don't have sound yet on our end, though, just to let you know. I don't have any sound on my end, just to let you know.
Aims to break the silence on rural aging and stigma of dementia. What changes can we make? What actions are needed? And how can we work better together? Every voice matters. People living with dementia, care partners, practitioners, researchers, and policy makers. Many voices leads to innovation. Innovation in research, innovation in practice, and innovation in our policies to improve the quality of life of people living with dementia. Together, we can make a difference to end stigma of dementia.
All right, and I'm just going to hop back over here. All right, so that concludes our presentation and all of our information about our new newest venture, the PHARR Center at Thompson Rivers University.
Thanks so much. That's so amazing. It didn't work so great for the video on my end, but I got pieces of it that were really amazingly connective and so echoed the community that was there.
Yeah, it's always a bit tricky with technology. You never know. That's why I love just providing the link and then everyone can, it just depends, I think, on the internet speed that everyone has.
For sure. There we go. Playing with buttons in the background. My apologies. So I'd invite from the audience to enter some questions in the chat. I see we already have some coming through, which is lovely. So I'll read them out for you, Juanita, and if you need any clarification, let me know, and I'm happy to facilitate conversation over. If someone living with dementia and or family wants to be involved, what's the best way to connect with you, and what can they be involved in?
For sure, definitely. So on our webpage, we always post our opportunities for participants where we're looking to collaborate with the community. So the website that we shared, as well as my email, if you just reach out to me directly, that's another great way to connect with me. I do a lot of work with the Alzheimer's Society of BC, and so I do a lot of partnering with them. So if you even let them know and you say, hey, I've heard of the work at the PHARR Center and Juanita, and they'll be able to put you in touch with me as well.
Lovely. And so I'm hearing that the PHARR Center is just kind of in its beginnings. Which is so lovely and very community driven. And I appreciate that point, being that, community-based research and patient-oriented research is a huge part of my work, and ensuring that the voice of community is elevated in all that's in my world. So I really do appreciate that. What would you say, like for the community level voice, would you say that it's present from all areas of the province, or are you focusing more on reality at this point? Like, what would you say is your growing population?
For sure.
Yeah.
That's a great question. So our work is very much focused on, BC is a massive province, and so our work is very much focused on interior British Columbia. So very much focused more inland here. But with time, we hope, to grow and connect with other centers and expand our reach and focus in our networks.
Sure. And thinking on that too, and thinking of how ways that potentially, attendees, I know we have many different, provincial standing attendees coming to Interior Health Research Week, and thinking of that partnership, what would be a way to be able to connect in, or how would we be able to say for the patient partner groups too that we're connected in with, for example, the Patient Engagement and Research Committee that I support that sits with the Interior Center, how might they be able to connect in and kind of grow that scope and network with you?
For sure. So at our workshops that we host, we try and make sure we reach out to as many organizations as possible. We were very fortunate. We had Interior Health at our last workshop. Alzheimer's Society, again, of BC is just so phenomenal, as well as different groups from across the province. So, if you're interested in connecting with us, if you just shoot us an email, or if we hear about you, chances are we'll try and connect with you as well. And so it's just that partnership building process.
Thank you. Thank you. And another question as well. Are you able to share examples of how people with dementia experience being able to share their stories and voices with PHARR?
For sure. Often, so I've been doing dementia research for a number of years now, and often there seems to be this focus on end of life, the end of life stage, and just almost a really strong stigma attached to people living with dementia. And so often people will ask me, how do you conduct research with people living with dementia? And they have this kind of depiction of someone in a hospital bed, frail and elderly. And so that's one of my goals when I do my research, is really breaking that stigma and that stereotype of people with dementia, and letting people know that it is possible to live well with dementia, and there's multiple different stages of dementia. And so it's not necessarily just that end focused, but it's, across the stages, and you can live well. So it is possible definitely to engage and participate and collaborate with people living with dementia. We do it all the time, right? So I'll co-present with people living with dementia. When I host workshops, I'll invite panelist discussions of people, for people living with dementia. I'll also invite different panelists of care partners living with dementia. So we have multiple different kind of perspectives coming out there. And then we ensure we invite policymakers as well as healthcare practitioners and students, because we want to ensure that, those stereotypes and that stigma is being broken, where they're seeing people that are, functioning and living well with dementia and able to really share their voices and what they want to see and have heard in research.
Well, I think that your multidisciplinary team, that you, even in the pictures that you were showing, really shows that you're wanting to grow that scope. And yeah. Another question. Are there more opportunities for students to be involved each year? And can they be from other universities, colleges, as well as TRU?
Oh, 100%. I love that question. It's fantastic. So just this summer alone, I had over 8 different RAs working with me on our dementia research, and all over across Canada. So I'm also a co-lead with the Canadian Consortium for Neurodegeneration and Aging, the Stigma and Social Inclusion Group. And so often it's great. I have the opportunity to bring in students that are from different universities. So there's one from Queen's University that was working with us this summer, one out at Dalhousie, just across Canada. It's great to have students mix and be able to share experiences. And then often too, there's faculty that I collaborate with across Canada. And so to have students be able to have that mentorship at a national level and start forming networks and having the community partners forming networks with different people with lived experience, it's just really great. And definitely with time, there will be more opportunities for students. But already we have such a huge group of RAs. I love being able to mentor students. I don't know, it's one of my passions. There's an international mentorship program, actually. It's called Advancing Gerontological Expertise in in aging, and I've developed that organization with the Gerontological Society of America, and so I run that monthly, where I provide mentorship opportunities to new and early career faculty in gerontology to increase their productivity. And so it's one of those areas that there's always going to be students working with us, because it's just training the next generation of researchers to support and healthy aging of older adults. It's so huge.
Mhm. We're doing it in such a good way, again, with that community base, right? Making sure that that voice is elevated up.
That's right. It's all about Barbara Israel.
It's a good thing. So I'm recognizing there was reply back. That's amazing. Student opportunities and mentorship. Agreed. I echo that. Sorry, I'm scratching my dog. It looks like I'm doing something weird in the camera. I just noticed that. So I recognize that we are early with time, but I wanted to offer space, just like one more space, if there's anything you wanted to leave with folks before we transition over about this amazing work, about the PHARR Center, or about anything else you'd like to share. I'd really like to give platform to that.
No, this has been such a great opportunity. Always love to come and present, whether it's sharing our research like last year or getting to actually share the opening of the PHARR Center. So great.
Well, we look forward to hearing more as it moves along, and we welcome you back next year too. So if, I'm sure that there'll be so many updates to provide next year of where the PHARR Center is at and the collaborations to date. And please, I know that you're connected in already with amazing members of our team. I saw Paula Morrison in one of the photos, and I know Michelle Smith is on the line and connected in as well. Hence our connection to you. And so however we can be of support and connection, please let us know. We're happy to be friends. We're excited about it.
Fantastic. Thanks so much.
Thanks so much, Juanita. Okay. So next up, and I know we're a little early, but that's okay. Luckily, all our presenters were fantastic at arriving early for this event. So we'll just keep moseying along, as my granddad would say. So it's a pleasure to introduce our next speaker, who I was connected in with through one of my interior health team members, due to a connection with Michael Smith, Health Research BC, just connection there. And so I'm really delighted to introduce Dr. Khaled Abdelrahman, Assistant Professor in the Department of Anesthesiology, Pharmacology, and Therapeutics, Faculty of Medicine, UBC. And the title of the presentation today is Unraveling the Mysteries of Alzheimer's, New Insights and Promising Treatments. And I am going to replace my spotlight with you, and the floor is yours. Thanks so much.
Thank you so much, Kim, for this opportunity. It's been great hearing all the fantastic talks and initiatives, and thank you for inviting me to do this. I am a pharmacologist by training. Well, and pharmacologist and pharmacist by training. So my talk will shift a little bit to talking about treatments and drugs and what we do in the lab. And I'm kindly supported by Michael Smith, Health Research BC, as Professional Investigator Award, and that's why I try as much as I can to actually talk about research, reach out to other people so that we can explain what we do in the lab. We would love the feedback. We would love people to reach and connect with us and let us know what they think about what we do and what we can do to make things better for Alzheimer patients. I will share my presentation. Can you see it? Good, great. Is it the presenter mode, right?
Yeah, I just see the slide. I don't see notes.
Cool, great. The title is Unraveling the Mysteries of Alzheimer's Disease, and I will start off by first acknowledging the land that we are located at. So our lab is located at the University of British Columbia Point Grey campus in Vancouver, And we acknowledge that the land at which we gather is the traditional ancestor and unceded territory of the Musqueam people. And also would like to first acknowledge all the people in my lab and the people who support, like the foundation that supports our research. We're supported by Michael Smith, as I mentioned, Alzheimer's Society of Canada, and Canadian Institute of Health Research, most recently. I had the pleasure to work with a lot of trainees, and I hope I will be able to show you some of the work that they have done in the lab and show how much we learned over the years about Alzheimer's disease and its pathophysiology. First of all, one of the main projects that we are working on in the lab is focused on Alzheimer's disease and understanding how Alzheimer's disease progresses. And before we go into that, I just want to quickly introduce two things that we'll be talking about quite often in the presentation. And we consider the pathological hallmarks of the disease. So if you see them in the brain of Alzheimer's patient, then they definitely have Alzheimer. And those will include the beta amyloid plaques and the tau tangles. So the beta plaques and the tangles. And they are essentially two toxic proteins that can be found in the brain cells, and they do play a major role in disrupting how the brain communicates. And therefore, a lot of effort is being put forward to understand how they affect the brain and how can we, for example, in an Alzheimer's patient, how can we protect the brain cells from the harmful effects of those toxic proteins? So that's the first important housekeeping notes that I want you to keep in mind. The beta amyloid and tau tangle are two of our toxic proteins that we're trying to understand more about and try to target. Second most important thing is the sex difference in Alzheimer prevalence and incidence. So this is was actually shared by the Alzheimer's Society of BC, and it really showed that there is a major difference between incidence and prevalence of Alzheimer's disease between males and females, with females being more affected and accounting for 2/3 of the cases of diagnosed cases of Alzheimer's disease. This is important because we need to understand what are the basis for such difference in order to be able to develop better therapeutic strategies. Because if there are differences between males and females, that means that there are also differences in how they respond to medications and treatments. So a better understanding of the mechanisms or the basis for this difference will, of course, put us in a better position when it comes to treatment. In terms of existing drugs that we have in the market right now for the treatment of Alzheimer's disease, I don't want to bore you with a lot of details, but there are two major categories that we have in Canada. The first category is anticholinesterase inhibitors, and those are the three drugs, the essential three. I'm not giving an example, there are only three. Right here, and this is Aricept is one of the most used drugs for treatment of Alzheimer's disease. And this drug is essentially working by increasing a neurotransmitter in the brain called acetylcholine, and this improves memory. The other category is anti-glutamatergic drugs, which essentially blocks the effect of another neurotransmitter called glutamate. And those are the two available drug classes in the market. So only 4 drugs approved for the treatment of Alzheimer's disease. Now there are, of course, there are major problems with those 2 drugs. We still use them because those are the only option, but there are 2 major problems. First, they only treat symptoms. So they only improve symptoms, and they mostly work in the early stages of the disease. So you keep, like, as a disease progresses, you try to increase the dose, but then at some point it really does not help. Because it only treats the symptoms, it does not really stop how the disease progresses. The other thing is, especially for this class that is mostly used, this drug is not really used clinically, but this is the most heavily used class. They come with a hefty list of side effects. Adding to that, the population that we're treating are usually geriatric population. That adds a lot to the weight of these side effects. So a lot of side effects that are really bad, so that some people even stop the medication because of the side effects. So they're essentially, what I'm trying to say here, that there is a dire need for novel treatment, better treatment in terms of side effects and efficacy for the patients. Now, there is a new drug class that is that's been approved in some places, including the United States, for the treatment of Alzheimer's disease, and those are antibodies. And those are essentially antibodies that bind to the plaques, beta amyloid plaques that I talked about in the beginning, that I said they are toxic. So the antibody binds to those plaques, and then those plaques are kind of cleared from the brain. And they are very effective. And in fact, they can indeed slow the progression of the disease, because they are getting rid of the toxic proteins that are responsible for the progression. So if you get rid of this protein, then you'll probably stop the progression. There are three antibodies that's been approved, that I said, in a lot of places, not in Canada yet, but it's coming. So there's lecanemab, and donanemab, and they are, as I said, effective, very expensive. And the first one that was approved, this one, Aduhelm, had a lot of side effects, some major side effects at least. And then this was improved with the new generation of antibodies, and even much more improved with the latest one that was just approved last month by FDA. It does have better efficacy and less side effects. But of course, they are very expensive as treatment, because they are only available treatment and they are antibodies. So it's the cost of production of something like this is very expensive. But they are one promising avenue for the treatment of Alzheimer's patient in terms of reducing the progression. What we're trying to do here is we're trying to test new targets that can also help with the progression of the disease, so slow the progression of the disease, other than this targeting the beta amyloid. And essentially what we're doing here is we're trying to indeed reduce the formation of beta amyloid in the beginning, in the first place, so that we can reduce accumulation of this toxic protein and probably the toxic effects on the brain. So now I'm going to move to the research that we do in the lab, and how this is advancing our understanding of the disease and the therapeutics. I do like a class of receptors and that is present in our genome, and kind of account for a lot, or play a key role in almost every function, every biological function in the body. And those class of receptors called G protein coupled receptors, or GPCRs. So GPCRs is a class of receptors. So our body's full with receptors. Those receptors are responsible for sensing any chemical or drug that is circulating in the body, or that kind of taken from outside. And GPCRs is kind of a major receptor class in the body. And they are targeted by at least 30 to 50 clinically used drugs. I'm not talking about Alzheimer, I'm talking about the whole spectrum. So if you go to the pharmacy and walk in the pharmacy, you look at the drug, at least half of the drugs that you see in the pharmacy approved, they target one of those GPCRs. We know at least 1,000 GPCR in the body, but there are way more GPCRs that we don't know their function or how they are regulated. I don't want to bore you with a lot of details, but I'm gonna jump right into the drug or the one receptor that we actually studied, and this receptor is called mGluR5. mGluR5 is a receptor that is present in the brain, in a lot of places in the brain, but it's present mainly in the area where that is responsible for memory, formation of memory. And that receptor is key in learning and memory. So research has shown that the receptor is key for learning and memory. So what we wanted to do is, the other thing that we know as well about this receptor, that amyloid beta that I talked about can actually bind to the receptor and affect its function. So what we wanted to do here is we wanted to use a drug. We use a drug that is can be orally administered, and it's very selective to that particular receptor, mGluR5. It has a decent or long duration of action, so it can be, these are concentrations that you have to think about in terms of dosing. So it has to have, have to have a drug that stays in the body for a decent amount of time, so they just don't take a pill every 1 hour or every 2 hours, because it's inconvenient for people, right? So it has to be long duration of action, oral, of course, because it's better than any kind of administration route. And we use this drug, and we wanted to see whether this drug can improve the memory function in mice, because we know the receptor is involved in Alzheimer's disease. So if we try to target that receptor with this drug, CTAP, are we able to rescue or change or improve memory function? And of course, we opted to test in male and female because we know that there are differences, and we wanted to study these differences. My lab is mainly focused on studying mice because this is what we can do, the capacity of our lab can do. But of course, we strive to validate our findings in human tissues using biobanks. So in this particular study that I wanted to talk about, we used male and female mice that were sick or affected, sick with Alzheimer's disease. So they have Alzheimer's disease. So the genetic makeup makes them more vulnerable to Alzheimer's disease. We give them CTAP and chocolate pudding. So they love chocolate pudding for some reason. Mice love chocolate pudding. So we give them the CTAP and chocolate pudding. And we then assess their memory function after we treat them with that particular drug and chocolate pudding for 12 weeks. So we treat them for 12 weeks, and then we assess how their memory function is affected or not. The question that I always get when I talk about these things to almost every audience, how do you test memory function on mice? Because this is not easy. So I will explain a couple of the cool tests that we use in the lab to study memory function. The first memory function test is a novel object recognition test. And in this test, what we essentially do, we do the test over 2 days. The first day, we'll place our mouse in a white box with 2 objects, and those 2 objects could be anything, cups, funnels, toys, whatever it is, but they have to be 2 identical objects. So the mice will start, when they are in a box, they start to explore the area. So they start to explore those 2 boxes. This is a natural mouse behavioral. Since the 2 boxes the 2 objects are very similar, they kind of spend equal time exploring both because they are similar. So and the next day, we introduce a new object. So we'll leave one of the objects that we used in the previous day and introduce a new object to the box. And the typical mouse behavior that they do like to explore the new object because this is new, I don't remember. I do remember that I haven't seen this yesterday, so they like to explore it. So typically they spend more time exploring the novel object versus the familiar object. But in Alzheimer mice, because they don't have that memory, they can't build that memory, that they remember that the two objects are actually, like one of the objects was from the day, the first day. And the second day, they actually spend equal time exploring both objects because they don't remember that this is new or this is familiar. They're both new, so they explore the two objects to a similar extent. So this is a novel object recognition test. The other test that we usually use for assessment of cognitive function, what we call Morris water maze. And the water maze is a fun test. We have a big pool of water, and we have a platform, and this platform is kind of submerged in a certain quadrant of the pool. And we put the mouse in the opposite quadrant and we let them swim, and the mouse keeps swimming until they find the platform, because they can't stand on the platform and they don't have to swim. And it seems like after 4 days of training, so every day we do that multiple times a day, so 4 times a day for 4 days, the mouse start to build that memory of, yes, the quadrant is present in this part of the pool. So when you put them in the pool, they just swim directly to the quadrant. But if they don't have ability to build this memory, they will, every day you put them in the pool, they would keep swimming all over the pool without finding the platform. That's essentially how the test is done. Interestingly enough, what we found that CTAP, the drug that we use for that particular receptor that we talked about, improved memory and reduced the amount of toxic beta amyloid in the brain. But this happens only in the male. It was completely ineffective in female. It was not able to do anything in the female, not improve the cognitive function or reduce the toxic A beta in the brain, and that's was contrary to what happened in males, where we found an impressive improvement and impressive advancement in or reduction in toxic beta amyloid plaques. So this paper, when we published it, people were really interested, and it garnered an overwhelming media coverage, because it was kind of one of the few occasions where we actually show solid evidence for key differences in terms of how males and females respond to drug, specifically to the receptor that I was talking about, the GPCRs. Nobody have actually shown this, and we were interviewed by CBC, by a lot of national and international news outlets to talk about this study and explain the details. But the one question that we always get at each interview: what are we going to do for females? So if you show this drug is effective in males, what are we going to do for females? And this is when we started to look for another target. And this is what I mean by targeting. We're always evolving. We're always looking for better targets that we can use drugs for, that can slow the progression and improve memory function in Alzheimer's disease. So the next target that we looked into after mGluR5, which is also belong to the big family that I talked about, the GPCRs, is the M1 receptor, what we call the M1 receptor. This is another receptor in the brain that is also playing a key role in memory and function. You have to keep in mind that there are many receptors who orchestrate memory and function, so it's not only one receptor. So this is one of the receptor, along with the receptor that I talked about before, the mGluR5, play a key role in memory and function in the area of the brain responsible for memory. And what we did here, we also did very similar approach to what I talked about. We used a compound, and this compound is is oral, another oral compound that is selective to that particular receptor, the M1 receptor, and had very few side effects when we tested it in animal models to target this particular receptor. And this compound has a very long name, VU48, but for now we call it the VU compound that is targeting the M1 receptors. In terms of the study design, we opted for a different route of administration. It's still oral, but we gave the mice that drug in drinking water, and we wanted to see if this VU compound will improve memory in female mice, because we're not able to rescue or rescue memory function in female mice when we use the other drug that I talked about, CTEP. So in this one, we tried to give them, the female mice, that particular drug in drinking water, and we tested the memory after treatment. And we used very similar memory function test to what I talked about. We were looking at novel object recognition, Morse automates to see if there is an improvement when we treat with that particular drug. And what we found that VU actually improved memory function and reduced the accumulation of A beta. And here I'm showing you a picture of an area in the brain. So this is a section in the brain, and this area is called hippocampus, which is responsible for memory. And what you see in dark brown here is the amount of plaques or A beta plaques that deposits in the brain, and you can see how extensive it is in the brain. And this, you can imagine how this can actually influence the memory function. When we use this VU compound for only 8 weeks, you can tell the difference, of course, in terms of the amount of A beta that is accumulated in the brain. So we found a significant reduction in the amount of the plaque after only 8 weeks of treatment. This all happens in females. So we have a reduction in A beta, we have an improvement in memory function in female mice. But now we're back to the question: what about male mice? So is this drug will be effective in males and females, or only females? This is ongoing work in the lab right now, but it seems like we are also able to rescue and improve memory function in Alzheimer's disease and in male mice using that particular compound. So it kind of looks like it reduces improved memory function in both males and females. However, the data that we have right now really clearly shows that the mechanisms by which this drug is improving memory function in male is really strikingly different than females. So there is this, although the drug improved the function in both, there is this sex-specific difference in how it's doing this, and that we are trying to understand. And this is what we do right now in the lab, is we continue to understand the differences in pathophysiology of Alzheimer's disease between males and females, and how this can be, how can we target those mechanisms to improve or slow the progression, and whether the concept of tailored treatment based on how the disease is developing between males and females could be something that we should explore, because it's likely won't be one drug that works for all. It might be that we have to use different approaches based on our understanding of how the disease or the mechanisms are manifest itself in each sex. I don't want to talk too much, and I'll leave some time for questions. So I'll stop here after giving you a quick overview of what we do in the lab and what we found over the past few years. And I'll be happy to take any questions if you have any questions.
Thanks so much, Khaled. That's not the first time that I've seen a clip about the work, and I'm still fascinated by it. Yeah, I feel like there's so much I have still to learn, especially about pharmacology. And
Yes.
yeah, and I mean, I can, being, being female, I can say that there is definitely drastic differences between males and females. But I love that, or I don't love, I do love that that's being explored because
Yes.
that's a health equity issue that is definitely prevalent and especially in the literature that, validates more exploration. So I love that you're doing that. Appreciate that.
Thank you very much.
For sure. And I welcome any questions from the attendees. Please feel free to put them in the chat and I'd be happy to relay them over and facilitate that. Oh my gosh, where do I begin with mine? I was making notes.
Mhm.
Of course. I know that like the front and center question that I always have is I know that I believe that you're an HPI award recipient. So for those that don't know, that's through the Michael Smith Health Research BC kind of umbrella, and HPI means Health Professional Award.
That's
Yes,
Professional Investigator Award, yes.
thank you. Yes, Health Professional Investigator Award. And I know that part of that award was connected to patient partners, community partners. And I wondered if you could talk a little bit about that, about your plans for that or what's been done in past in this point.
Yeah, that's a great question. Thank you very much, Kim. So we try to so when I applied for that award, I had to put together a really comprehensive plan of how we want to do this. Very excited about it, but it was harder than what we anticipated because of the nature of the work that we do. But what we were able to do, and this is not my work, it's the work of fantastic coordinators that worked with me over the past. I've been supporting with them Michael Smith for a year now. So over the past year, we were able to reach out to a lot of long-term care homes, and we partnered with Alzheimer's Society of BC to also provide workshops and webinars to patients and healthcare providers and caregivers. So we tailor our presentation to actually educate people about what we know, what we have, what are the treatments that we currently have, what are the pitfalls of the treatment that we have, what do we need to work on, and what are we actually doing. And the purpose of this, from my perspective, was first to make sure that our research is accessible to everybody, so everybody understand what we're doing. Of course, we're kindly supported by brands who comes from people, so people need to understand what we do first. Second, to actually hear the feedback, because sometimes as researchers we get really focused on what we do and we forget a little bit about the bigger picture. So it's important to every now and then to talk to people who are actually with lived experience to hear what do they want to see in the future, what do they want to things that needs to be addressed. And this could be something out of scope of my expertise, but I can relay this to someone else from my connection or from my network. As an Alzheimer researcher, I have no other people working on other fields or other research disciplines, so reach out to them. You know what, I heard this great idea, why don't you work on this? And this is how we move things forward and prioritize our research efforts and help patients as much as we can.
Thank you. Oh, and then in the chat, amazing opportunity. Families struggle looking for solutions, and something to slow progression would be such a benefit for quality of life. Oh, agreed. And care for people living with Alzheimer's and families. So thanks for that, Michelle.
Thank you very much, Michelle. Thank you.
And she also says, really impressed that you engage with people living with Alzheimer's and their families, caregivers, and learn about their lived experience. There's such that's where really the heart of everything comes from. I mean, that's, I'm sure, the reason why you're doing what you're doing is because that's to support people
Yes.
that are living with this and that have their circle of loved ones and care, and the ones that care for them. So yeah, I agreed. I wondered, because I know we have a range of folks that have joined us, because we do open Research Week to everyone. I wondered if you could talk a little bit about clinical trials and about how, you know, your work, how it's kind of evolving forward to be able, because I'm assuming if it's happening in mice right now that it hasn't come for public use yet. But I wonder if you could talk a little bit about, you don't have to get too far into the weeds, but a little high level would be great.
Yeah, well, yeah, happy to do this. So for like just to set the stage for everybody, so that for any drug to come from creation to clinical application, it's a very long journey. So start first by, of course, sensitizing a whole bunch of molecules. We're talking in the thousands, and then you start to get there are tests that are doing like high throughput screening. For example, if this drug is supposed to work on certain target, then you do screening for these components. See what compound of those those thousands of compounds is actually selective to that particular target. And then you do that in kind of what we call in vitro models that involve some cells. So like cells, isolated cells in the dish, and you just see your selective or effective drug. And then you move on next to the preclinical stage, what we do, which is in mice. So you try to test that particular drug in mice, and then after you test it in mice, if it's effective and it's looking promising, then can move to non-human primates. So we do it in mice and maybe other species like rats if possible, and then move it to non-human primates, so monkeys, if that's also, well, has to be available, so that you try the mice and monkeys and make sure it kind of holds efficacy and safety that you have seen in mice. And then we move to clinical trials, and clinical trials are usually 4 stages where it ranges from testing in healthy individual to make sure the drug is safe and effective and reaches a concentration to where it's supposed to do, and then testing this on a small group of patients with this particular disease. So if it's Alzheimer's, so a small group of Alzheimer patients, test the drug and see if it's effective. And then if it's effective, then you move to kind of a bigger cohort of patients in the final stage that includes multiple centers around the globe. And if it's effective, then it gets an approval from the approving authority. And then this one, the last stage or stage 4 of clinical trials starts with what we call the post-marketing surveillance, which is essentially the monitoring of any side effects, problems, anything related to this when it comes to efficacy in that particular state. But this is after the drug is available for people to purchase and use, of course. What is really interesting, I want to take a moment to talk about this particular issue with clinical trials, is that in the beginning of 2000, FDA had to withdraw at least 10 drugs or so over, I don't remember the period exactly, but over a certain period of time, they withdrew about 10 drugs from the market. 8 of them were withdrawn because of their side effects or unfavorable effects in females. So it was because of, our lack of knowledge of how these drugs are acting in males versus females. So that gives you an idea of how much we need to learn early in the process, like what we do now in the preclinical stage, about the effects of drugs in males and females before we actually move ahead and move these drugs to clinical trials, so that we don't run into the same issue again.
Well, I appreciate that, and I appreciate how I appreciate too how you shaped that and interwove it with the concepts of health equity that we heard earlier today, and also the concepts we heard earlier today too about community-driven, patient-oriented research, and how those threads are so important to shape the outcomes that we want and desire for ourselves and for our communities and for our loved ones. And I really, really appreciate that.
Thank you so much.
For sure. I don't see any other questions come in, so I want to give you space to share, your hopes for next steps, or your anything you want to share. This would be a good time to share it.
We hope to continue to engage with people and to find the platforms where we can engage with people like this kind of invitation. I struggle a lot, and I'm not blaming anybody, but it's a bit hard to find such platforms where you can, pitch your research to people who are most affected with what you're working on, and show them the progress. We try to reach out to multiple outlets, but we're not successful. So really appreciate this opportunity. I would love to see more of this in the future, so that we can indeed engage with patients. And I am even looking for, we even opened our door for patients and caregivers to come to the lab and see what we do in the lab. And there are actually 2 visitors that came to the lab, looked at what we do, and they were really happy to see real time our research efforts to understand or to develop new targets for the treatment of Alzheimer's. So we would love to do more of that, and engage with more people, and even trying to plan with my coordinator now a presentation or webinar where we have actually patients present with us. We talk about the work and have them talk about what we do, to explain it to other patients or caregivers, and have that meaningful interaction with people, so that our research and our efforts are well disseminated to the target audience and to patient partners.
Thank you so much. And Michelle says Michelle Smith with our team says she's going to follow up with you. And I know that we continue to support building connections, and we're happy to continue to do that. And I look forward to hear more about your work as it evolves forward. And I'm hopeful for not only the populace now, but for myself as I get older. So thank you so much for your time and for your sharings, and we sincerely appreciate it.
Thank you very much for that opportunity. I really appreciate it.
Okay, and I know we're early, but who doesn't appreciate some extra time back? I just want to say huge gratitude for all the presenters sharing their time and work today. Your work just has, we don't, and I've said this before and I'll say it again, sometimes we don't understand how far the ripple goes, but it's so important to start the ripple. So thank you for rippling and for creating waves in all that you do. I want to thank the audience and everybody for attending. I want to again give huge gratitude to Abdelrahman for opening up our research week, and for joining us again at the end of the week for our closing session, Cafe Scientifique, that's being held here in Kelowna. I do hear that we are sold out, but there is space for the morning event. We have a metadata comments. So if you're in Kelowna near UBC Okanagan and want to stop by, it's at 10:30 a.m. and more information can be found on the Interior Health Research Department events website. So thank you again so much. You're going to receive a feedback survey either when you close out this Zoom session, or tomorrow via email, and we welcome you to share your thoughts with us to help Research Week for all the years to come. And again, take good care of you and yours, and thanks again for being part of IH Research Week 2024. We look forward to seeing you again soon.